Okay, for my case study today, we're doing on subclavian steal syndrome. In this case study, we have a 90-year-old woman who has an extensive cardiac history and 15 years ago underwent artery bypass graft surgery. She's presenting to the ER today with symptoms of chest pain, dyspnea, and diaphoresis. So right off the bat, we know she has an extensive cardiac history. She has chest pain, she has difficulty breathing, and she's sweating. She has typical heart attack symptoms. Right off the bat, we're getting an EKG and we're getting an IV on her and drawing some blood so we can get some lab values. Her EKG is shown right here. It has ST depression across the precordium, so we have in many leads, 1, 2 leads AVL, V6, V5, we have ST depression. And then we have ST elevation in the AVR lead up near the top. We can see that elevation, and that ST elevation right there is showing us that she's having a heart attack. She's having a STEMI. She has ST elevation myocardial infarction. If we had waited around for the lab values to result from lab, we would have seen an elevated troponin level in her body. And so we're sending her off to the cath lab. In the cath lab, they're going to do angiography, and they use a contrast dye and x-rays to look at all the arteries of the heart and all the vasculature, and they're able to thread up a stent and a kind of a rod up through the radial artery or femoral artery to put a stent in where the occlusion is. On this woman, we have her angiography revealed totally occluded native coronaries and an occluded saphenous vein graft to the left obtuse marginal arteries. Those could be old from her past MIs because we know that she has bypasses and grafts all over. And the angiography showed the saphenous vein graft to right coronary circulation was patent, was the left internal mammary artery. And the left internal mammary artery bypass comes right off of the left subclavian artery, which is that third artery coming off the aortic arch. And the reason they did that internal mammary artery bypass was to reperfuse that left anterior descending artery and bypass that blockage in the left coronary artery and make sure they get that perfusion in there. However, what they did find was that she had severe left subclavian artery stenosis. She had 99% occlusion in that left subclavian artery, that third artery coming off the arch. That is really bad because her heart's being perfused by that internal mammary artery that comes off of that subclavian. So that subclavian is blocked, which in turn hinders that IMA bypass. With stenting, that's a picture right there of what a stent would look like inside the vessel. It's a wire mesh on top of a balloon. They thread that up into the artery where the stent is, and then they inflate the balloon and expands that wire mesh to push out that vessel, open it up, and help actually stop plaque and all that from breaking off and causing a clot later on in the bloodstream. One of the major things that can happen is subclavian steal syndrome with that left subclavian artery stenosis. In that left picture, we can see how the left subclavian artery is stenotic right there, and it's showing just a little bit of blood flow through there. And then with the arrows, we can see that we have reverse blood flow in that left vertebral artery going from the left subclavian. And that left vertebral artery is what's perfusing the internal mammary artery graft now, the bypass. And luckily for this 90-year-old woman, we have the circle of Willis that has many options for blood flow for the brain and for backflowing into the left subclavian, so it can still get a little bit of perfusion. Obviously, she's not getting enough perfusion because her heart is under stress from the lack of oxygen. And typically, patients are asymptomatic, but because she had that IMA graft, she definitely was showing symptoms. In patients with symptoms of arterial insufficiency, patients with symptoms of arterial insufficiency have different issues because they got stenosis all over, they got plaque buildups, blood flow is hindered all throughout their body. They're going to show symptoms in the brain, in their upper extremity, and then with their heart with an IMA graft. Clinical manifestations in that upper extremity, we'll see claudication, so pain when they're exercising, or they're going to have weak or absent extremity pulses, or cyanosis in the upper extremity. And they may also even see differing blood pressures in each of the arms. So the left arm's going to be lower in blood pressure than the right arm. This can also occur on the right side if we have a right subclavian steal syndrome. We also have TIAs, so transient ischemic attacks, so a mild stroke that will resolve symptoms typically. Recurrent vertigo, hearing loss, or tinnitus, positional nystagmus. So we're going to see all that blood flow that goes to the head to the ears. We're going to see that hindered with these symptoms. Right here we have an echo ultrasound of a normal aortic arch with a view of the suprasternal window. Up near the neck, we're looking down on the aortic arch. We're able to see part of the ascending aorta, the arch, and then the descending aorta. And then we can see in these images a clean brachial, cephalic, left common carotid, and left subclavian arteries. They're all open and wide and clean. We're looking at, on the right picture with color, we're looking at the flow of the aorta, and it's all looking good, nice, non-turbulent flows. Here we have actually a normal ultrasound of a severe stenosis in the brachial cephalic artery. This isn't the 90-year-old woman, this is another case, but this is showing great images, echo images of a severe stenosis on that brachial cephalic artery. And we can see that just wisp in the color Doppler image. We can see that little wisp of flow through there and into that brachial cephalic, little turbulence there at the entrance. And this is actually potentially going to cause a right subclavian steal syndrome on that right side with the right vertebral artery. You know, with this access of imaging, we're not really seeing those other left common carotid and left subclavian very well, but we can kind of see those. Can't see color on them though. And because of what we find with the regular 2D ultrasound and color, we're going to do a Doppler on there. And we're going to use continuous wave Doppler through the aortic arch and that brachial cephalic trunk to get that velocity, because with that narrowing, we're going to see an increased velocity. We can determine how severe this is. And we actually see a pretty significant velocity, 326 centimeters a second. Pressure gradient is 42 millimeters of mercury. It's pretty significant. So right off that, we're going to want to get a more accurate result by using a PDOF Doppler probe, which is a blind continuous wave transducer. We're going to use that because it's pretty much, it spends more energy on getting that velocity, not on producing an image. And we actually get an even more elevated velocity. We're getting 462 centimeters a second. Pressure gradient's almost doubled actually with the PDOF. So we get a more accurate picture of the velocity and the severity of this stenosis. And this is what we'd be looking at with the subclavian steal syndrome. Thanks.